Okay, it's 8 o'clock, so let's get started. I think I'm going to finish on time today. I didn't pull as many slides, but a lot of these cases have a lot of commentary, so I might not, so we'll see. Anyway, this first case is an 81-year-old woman with a complex cystic mass in left breast that was found on mammography and follow-up ultrasound. It's called BI-RADS 4A, and so a follow-up biopsy was performed. Now, I'm not sure how familiar you are with the BI-RAD system. Usually they biopsy things that are 4A and above. 4A is kind of the lowest risk. It's like a risk of malignancy for the radiologist, so take it with a grain of salt, of over 2% but under 10%. 4B is like 10 to 50%, and I think 4C is like 50 to 95% likelihood that it's going to be malignancy. So this basically, they're not that suspicious. It's less than 10% of the time. So it's kind of what we would call like mildly atypical, basically. So this is the biopsy that I got, and right off the bat, I can correlate their cystic lesion that they're seeing with what I'm seeing, because this is all kind of like cyst wall that's been hemorrhagic, a lot of hemosiderin. This is all hemosiderin, very fibrotic. It looks almost scarred, like small vessels present here, moving around. This is something that I want you to pay attention to. When you see a cystic mass and that's biopsied in breast, this is so often missed because you're looking for like big ducts and lobules in the stroma, but what you miss is the lining. So most of these cysts in the breast are apocrine cysts, like cystic apocrine metaplasia, and that's what you can see here. So now we know this is an apocrine cyst. Now the problem is it atypical or not? So most of these are not. The vast majority are just benign. Also, this is not just regular blood from a biopsy and bleeding from a vessel. This is actually cyst debris contents. It's kind of like organized blood. It doesn't look like regular red blood cells. This is also something I find is helpful, but typically missed and just thought that it's procedural blood, which it's not. So a lot of times that's all you'll see is just kind of something like that. I'd call it, consistent with cystic apocrine metaplasia, etc. This case is different though, because you start seeing a lot more of this apocrine metaplastic epithelium. Now this looks very complex, but it's fragmented. There's no wall here. This is just kind of a fragment. Is there any way this is tangentially sectioned? Sure, it could be. Deciding if you have atypia with an apocrine epithelium is really difficult because the atypia and apocrine metaplasia is basically more pronounced features that they already have. So the cells, sometimes they're always rounded, almost always rounded, and they have prominent nucleoli. Well, apocrine metaplasia has rounded nuclei and prominent nucleoli, so that's not going to really help you. It's kind of degrees. So if it's really prominent nucleoli or very large and rounded nuclei, when it's high grade nuclear atypia, that's easier. It's still, I think, difficult in apocrine metaplasia. I think this is kind of a underappreciated, difficult aspect of breast pathology. A lot of breast pathology is difficult. I think apocrine metaplasia and deciding when something's atypical is hard. So I think a lot of people maybe would just call this apocrine metaplasia. To me, this was too architecturally complex to call it just benign apocrine metaplasia. So then the question is, what do you do? How do you decide? If you're dealing with UDH versus ADH, you can do CK5-6 and ER. ER is strongly positive and ADH, low-grade DCIS, CK5-6 is negative. It's the opposite staining pattern in UDH, where ER is very weak and patchy, and CK5-6 is that mosaic pattern. You can't do that here. Apocrine metaplasia is ER negative, whether it's atypical or not. CK5-6 is not going to be helpful. So here you have to really just go based on morphology. And so for this, the architecture was atypical to me. And then cytologically, I found this area. These are too big a nucleoli to call this anything other than atypical, worrisome for DCIS. This looks kind of high grade to me. Look at how big those nucleoli are. So it's focal. A lot of this doesn't have this. Now, in the context of what I was seeing with this very thickened cyst wall, the fact that they saw a cystic mass, that sounds like encapsulated papillary carcinoma. And you can have an apocrine version of that. It's very rare. I've seen one other case, and I thought that's what this probably was. I was doing that based on the architecture. You know, I said that maybe that one section was tangential. Well, then, is that tangential? Is that tangential? No, there's too much of it at that point to try and sum up all of this by saying it's all tangential. There's way too much of this complex apocrine epithelium to assume that it's all tangential, even though a lot of it is not that atypical. Every once in a while, you'll get really prominent nucleoli. Again, you get distinct nucleoli in apocrine metaplasia. This is too much. So what are you going to do? What are you going to call this? So I'll show you how I signed it out. I signed it out the typical way that I do when I'm nervous, which is a really long comment. I call it complex and papillary apocrine proliferation, suspicious for apocrine encapsulated papillary carcinoma. So then I basically talked about how I came to that distinction. There's no stains you can do. That I thought this is probably a variant of encapsulated papillary carcinoma. Again, those are really rare. There haven't been many described, but that these are staged as DCIS kind of lesions, TIS, and then I recommended excision with clear margins. That's kind of the main thing. And I called this nurse practitioner, explained everything to her, and then waited anxiously to see what the excision looked like. So here's the excision, and here's this big cystic lesion, and you've got some biopsy site. So this is that bovine collagen that's injected. There's a filler with the clip. So we know we got the site, and most of this is just cyst. And I was like, uh-oh, you know, is there not going to be anything left? And then what do I call it if there's nothing left? But there was some stuff left. And again, it's very complex and it's very atypical. You have really prominent nucleoli, very coarse chromatin. And again, this is, you know, you've sampled these very extensively. You look for anything that looks invasive. Usually these apocrine encapsulated papillary carcinomas don't have associated invasion, but they can. There have been ones described. Again, I think the other discohesion, see how discohesive this is? That's another thing that I find helpful with apocrine atypia and calling something malignant. It's kind of similar with Hürthle cell lesions. Well, we call them oncocytic now in the thyroid. When you FNA them and there's a lot of discohesion, that's something that's a worrisome finding on cytology. Here again is this big cystic mass, and most of it's gone, but here there's a lot of it. This is way too complex. Most apocrine, so this is basically a form of apocrine DCIS, and it's an apocrine encapsulated papillary carcinoma. See, notice this does not look like regular apocrine metaplasia anymore. Now that you have it all, it's kind of solid in this area, very vesicular, very prominent nucleoli. You know, you can call apocrine DCIS low grade, intermediate grade. Most of them are high grade. If you're going to call something a low grade apocrine DCIS, you have to have perfect architectural features that are clearly cruciform. You know, you can't go by papillary and micropapillary because those are common features you see in normal apocrine metaplasia. That's what makes it even more difficult. So you need something really solid or really herbiform, good Roman bridging. If you only have a little bit of it and you have kind of bland nuclei, then that may be atypical apocrine hyperplasia. And in that case, you know, it's based on size criteria, just like UDH or ADH versus low-grade DCIS. Is it over 2 millimeters? There's no consensus with regards to apocrine atypia in the breast. So you really want something a lot bigger, I think, because so much of this is very subtle. But again, look at this is high grade. If you see necrosis, obviously that makes it easier. But these very vesicular nuclei, large nuclei, really prominent, multiple nuclei. This is basically apocrine encapsulated papillary carcinoma. What made this case kind of more difficult is that there's a lot of like radial scars in the background and a lot of regular apocrine metaplasia. This is right next door. This is not atypical. Notice how this has more of a good, well-formed polarization with these really prominent granules that you see apically, the eosinophil granules in the cytoplasm. But even here, you know, this is benign, but you can see normal apocrine metaplasia has distinct nucleoli. So it's really something you have to kind of take every aspect of it together. Again, that's looking a little atypical, but in the context of a papilloma or a radial scar, you just would blow this off, and I would too. This is benign. But again, you compare that to this over here, this is way too complex, and these nuclei are even more atypical. Again, it's all kind of grades, very much more atypical. So this was the other case I had as a core biopsy. This was several years ago in another practice. And again, this is very similar to what I see. And that's why I kind of recognize this, because I've seen this before. And when it came out, it ended up being seen at MD Anderson and somewhere else, I think, too, when they called it an apocrine encapsulated papillary carcinoma, which is what I suggested on this core biopsy, because that's kind of what it looks like. It looks like a regular encapsulated papillary carcinoma with the thick wall and then very complex cribiform looking proliferation that in this case is completely apocrine. But again, notice in this case, there's not the significant nucleoli that you saw in the other case. So this kind of is more of a low-grade looking appearance. Again, very thick wall, which is what you want to see for these encapsulated papillary carcinomas. So that was my first case I had. Now, I'd mentioned that a lot of times when you get these core biopsies and they're looking for something like, you know, a cystic lesion that was biopsied, it's easy to miss. And this is what you need to look for. You look for these fragments of breast tissue where the lining, because if you think about it, when they're biopsying a big cystic lesion, they're just going to get the edge of the wall. So all you might see sometimes is a little bit of apocrine metaplasia along a fibrous wall. I'm telling you, these are often missed. Sometimes it's denuded. Sometimes you only have a little bit. A lot of times you'll see the wall of the cyst that was being targeted, and you'll say, oh, well, there's mild PASH, because fibrous walls of cysts often look like PASH because they have these kind of slit-like spaces, just because they're kind of sclerotic, kind of like PASH. But again, if you see some more intact apocrine metaplasia, which you often do, you know, usually an apocrine metaplastic cyst isn't just a solitary unilocular cyst. There's often other apocrine metaplasia around it. So just be aware of that and look for those kind of subtle features on the periphery. Now, this is the typical usual type or classic type of encapsulated papillary carcinoma. These are usually postmenopausal women. They're very thickly encapsulated. Sometimes they're less thickly encapsulated. You can have DCIS on the periphery. That doesn't take away from the fact that this is a solitary mass. If you have DCIS around it, that means that the patient's going to probably have a higher recurrence risk. These are technically probably invasive carcinomas. You know, molecularly, they kind of lie in between DCIS and invasive carcinoma, because when you do myoepithelial stains, not only do you have loss of myoepithelial cells within the main lesion, you have loss along the periphery, but you still stage them as TIS or in situ carcinomas, assuming that the cytology is low grade, which this is. Now, usually, even though, you know, the encapsulated papillary carcinoma, these often look more cribiform than anything, and that's because between the papillae, which can be kind of subtle, you have a cribiform proliferation because this is kind of an atypical proliferation. But the base of this lesion is papillary, and then you often just have cribriform areas between the papillae. Again, low grade, these are ER positive, HER2 negative. You shouldn't be doing HER2 anyway because you treat them like a DCIS. But if this is ER negative and you get the case, you've already signed it out, you need to go back and look at it again because these are universally ER positive. If it's ER negative, you're not supposed to call it an encapsulated papillary carcinoma. If you do HER2 on DCIS, which some places do, even though it doesn't change management currently, and it's HER2 positive, it's not an encapsulated papillary carcinoma. High-grade cytology, it's not an encapsulated papillary carcinoma. You would call it, if it looked just like this and then you went to higher power, when you got to higher power, it's high grade, you call it that an invasive papillary carcinoma, and then you rule out a metastasis. So now this is a case, this is another encapsulated papillary carcinoma that I had years ago. And this one is really papillary. It doesn't so much have the cribriform areas between it. And so what you do with these cases is you look for invasive carcinoma around them because they can give rise to invasive carcinomas. When they do, they're typically usual type. But this is a very rare example of a true invasive papillary carcinoma. And this is the only case I have ever seen of invasive papillary carcinoma in the breast that is a primary breast cancer. And the reason this is papillary is because within these cystic kind of spaces, you get these fibrovascular cores. Most invasive carcinoma that has a papillary appearance or micropapillary appearance in the breast is micropapillary, where you get micropapillae within these retracted spaces. But this is actually a true invasive papillary carcinoma. It's really rare. When you see this, you should think about a MET, but in the setting of this lesion, you know it's arising from that. So that's an actual invasive papillary carcinoma, the only one I've seen in the breast in my career. Now this is what you more often see. This is an invasive micropapillary carcinoma. So how do you tell, first of all, how do you make the diagnosis? You need over 90% of the tumor to have this morphology where you have these little micropapillae within these retracted spaces where the polarization is reversed, meaning that the cytoplasm, the bleb of the cytoplasm is facing the retracted space. The other thing you look for is you look for multiple, to make sure this isn't an artifact, you look for multiple micropapillae within one retracted space so that you know it's not. If you wanted to do an immunostain, you could do EMA because the EMA will be on the outside. If this was a tubule that had a little central lumen and you did EMA and this is a retracted space, the EMA would be in the middle. And if it's a true micropapillary carcinoma, the EMA staining is on the outside. But again, here you have multiple little papillae within a single retracted space. If you have less than 90% and over 10% of breast cancer that has this morphology, you call it mixed invasive ductal or invasive carcinoma of no specific type with micropapillary, and you give the percentages. And about 2/3 of cases of invasive micropapillary carcinoma, when they're diagnosed, they have mets to the lymph nodes. So if you have a lymph node, a sentinel node in a case like that, you need to look really carefully because most of the time there are mets. Now, this is another case that I had here recently where it looks like an encapsulated papillary carcinoma from low power, but it's pretty solid, but it really looks like one. And then you go to higher power, and this is high grade. So this is not encapsulated papillary carcinoma by definition. And this woman had a history of serous carcinoma of the fallopian tube. So this is a MET. And you think, oh, ovarian fallopian tube cancer to go to the breast, that's really random and rare. It's not. It's one of the more common METs to go to the breast. It's probably has something obviously to do with the hormonal milieu of the breast and the ovary being kind of consistent with one another and this being able to grow well in the breast. So this is actually, besides melanoma, lung cancer, ovarian or tubal serous carcinoma is one of the more common METs to the breast I've seen several of them. And this actually raises a difficult, at least in the past, it raised a very difficult differential that was hard to tell apart. This was a case I had in Vegas back in 2009 or 10, where it was a woman that was known to have, several years before, a serous carcinoma, which at that time was called ovarian serous. It was probably tubal. She had genetic testing and she was BRCA1 positive. So then after that, and she was relatively young, they did breast imaging and found a solitary breast mass. And then they biopsied it and they wanted to know, is that a new breast cancer, which it absolutely could be with a BRCA1 patient, or is this a MET from her ovarian serous carcinoma? And this is what I got. At the time, there was no GATA3, there was no Pax8. All we had was WT1. And WT1 is often positive in some high-grade breast cancers. P53 can be positive and overexpressed in some breast cancers. Now, what I did, I tried to do the stains. It was not that helpful. But to me, I favored this was a MET, even though clinically they thought it was a new primary, because this was actually weakly ER positive. Women that have BRCA1 germline mutations that get breast cancer are usually triple negative. The fact that it was ER positive kind of paradoxically made me think that it was not breast cancer. The other thing is a lot of these basal type triple negative cancers in BRCA1 positive patients have a lot of tumor infiltrating lymphocytes. This one did not. Also, you know, I'm a cytologist. I see serous carcinoma in PAPS. This really looked like what serous carcinoma looks like in PAPS. But I favored it was serous carcinoma, but they didn't really believe me. And they said, is there anything else we can do? And there was a new company at the time called Pathwork Diagnostics that they had a test called Tissue of Origin, where you could send the block and they would do kind of looking for a molecular RNA signature and say if it was more likely one versus the other. And so I did that and sent it, and it came back that it was likely ovarian. So anyway, it's kind of now it's not a difficult immunohistochemical differential. 15 years ago, it really was. All right, so second case. It's a 4-year-old man with a slow-growing lesion on his left posterior neck for more than a decade with some pain. It's thought to be an epidermal inclusion cyst clinically, and so they did an excision. And I sent you pictures of this. So very solid looking, spindled looking. I can tell you when I grossed this, it was pale yellow, but firm. Now, normally a 48-year-old man, posterior neck mass, when I even hear that, I think it's a spindle cell lipoma. Grossly, it didn't look like the typical lipoma-like lipoma. It was yellow, but it was very pale and firm. And then this has this very hypercellular area, hypocellular area with a lot of nuclear palisading and a lot of like self or nuclear free cytoplasmic areas. So this, when you have this kind of very cellular area, nuclear palisading, hypocellular area, another hypercellular area, hypocellular area. When you look in the hypocellular area, you see these kind of ropey collagen, kind of looking like shredded carrots, which looks like a neurofibroma. That looks more cellular. This is like classic schwannoma. So to me, H&E, this was kind of a classic schwannoma. And you're like, well, it was yellow. Is that typical for schwannoma? Actually, yeah. Here, this again looks kind of like the Verrucay bodies. David Lewis, who is now the chair of Mass General Brigham. Before that, he was the chair of Mass General. Before that, he was just a neuropathologist that signed out. And when I was a first year, I signed out neuropath with him. And I remember him saying that there are 3 CNS tumors that you should think about if you're grossing a CNS tumor and it's yellow: a lipoma of the CNS, a hemangioblastoma, and schwannoma. So schwannomas are known to be yellow. So to me, it wasn't that unusual. You know, spindle cell lipoma, which I said is in my mind, was in my mind when I first heard the history. can certainly have very spindled areas. This seemed like a lot, and this alternating hypercellular, hypocellular areas like Antony A, Antony B, I thought was kind of typical of schwannoma. Again, this is kind of a typical look of schwannoma, but then there is some fat here. So then what do you do with that? Some areas there was a tiny bit more. Definitely a little more fat, but again, that's a real small minority of the tumor. Now, schwannomas can have tons of metaplasias. You can get chondroid metaplasia, osseous metaplasia, lipomatous metaplasia. You can get squamous metaplasia, glandular metaplasia. You can get basically every type of metaplasia in a schwannoma there is. And so, what I do for you guys is when I have an interesting case, I will have it written down in a Word document. And then eventually, I've already shown like 130 slides or something that I've gotten from this hospital. Right now I'm on like 280. So I kind of, usually when I show these cases, these are old cases. This is a case I had in 2024. And I put it in there and I specifically typed out, compare and contrast with spindle cell lipoma. So when I pulled, I'm like, okay, now it's June 20th. I'm like, okay, for my June case, I'm going to pull this old schwannoma with lipomatous metaplasia that I signed out in 2024. So I pulled it. I'm looking at it. I have it down. Obviously, I signed it out as a schwannoma. And I'm like, okay, well, let me pull the immunostains just to show what the immunostains are. And I looked in the file and I couldn't find them. And I looked in my report. I was like, I didn't do them. Like, why didn't I do them? I mean, it's so typical, like classic schwannoma. I'm like, you don't have to do them. But I'm like, you know what? With this fat, I should have done them. So I'm like, well, I'll do them now just so that I can present them to you guys. I won't charge the patient. I'll delete the charges. So I ordered them, and like a couple weeks ago, I got them back, and this is the S100. So, schwannomas are diffusely strongly positive for S100. The fat is positive, but the actual spindle cells are dead negative. I got SOX10, dead negative. Should be strongly positive in a schwannoma. And I also got CD34. CD34 has very patchy, predominantly negative schwannomas, is diffusely strongly positive in spindle cell lipomas. So this is the CD34. This is a motherfucking spindle cell lipoma that I signed out a year ago as a schwannoma. So now let me tell you, when I realized what I had done, for a period of about, I'd say 90 seconds, I yelled every single obscenity in my very broad lexicon of swear words, most of which included some variation on the word fuck. So to say I was upset is an understatement. Now, once I got my heart rate under 100 and was able to get my shit together, then what do you actually do? Is this a big deal? Well, to me it is. No one wants to make a mistake. And let me tell you, most pathologists that would have pulled a case like this for a conference and then realized that they made that mistake would have presented this as a spindle cell lipoma and not been honest about it. Believe me, I have my areas where I lie, specifically when I'm pulled over by a cop for speeding. I always am coming to a frozen section. And that always works, by the way. But in this case, I felt like, just to be intellectually honest and to go over how do you handle this. I thought this was a good opportunity to talk about how do you handle mistakes when you make a mistake like this. So actually the CAP deals with this, and this is one of the standards. And it's that the laboratory issues an amended report and promptly notifies the responsible clinician or clinicians when there are changes to the reports that affect current patient care. Does this affect current patient care, calling it one benign tumor to another? Probably not. But, I still felt like I needed to amend the case. So I actually did amend the case. This is kind of more meant for the 5-year retrospective review for PAPs for HSIL. So if you have an HSIL and then you see that you had a negative PAP within the last 5 years, you're supposed to pull it. And the only time you amend that case is if the change in diagnosis will change the management. So if you go back and 3 years ago, you call the pap negative and it really was HSIL and you missed the few cells that are there, you made a mistake, but you don't amend that case because there's nothing that's going to change the current management. Now, if you go back and you see what looks like classic AIS or something that looks like invasive squamous cell carcinoma, yeah, you have to amend that case because that's going to change the current management versus just what the current PAP is HSIL. So this I didn't think was going to change it, but I still felt like I didn't want that report out there. Also, schwannomas, even though solitary, they're almost always sporadic. When you get multiple of them, you can start thinking about NF2, germline mutations. There's no malignant risk for either of them, spindle cell lipoma or schwannoma, but regardless, I changed it. I talked about, what I did in preparation for a teaching conference. I thought about the differential more, got the stains, said regardless, both of them are benign, don't have malignant potential, and I called the clinician. You always have to make sure the report says amended report, which it did, why you amended it, talk about it, call the clinician. So I did what I was supposed to do. I wasn't happy about it, but I did what I was supposed to do. And again, you could argue that I didn't even have to do that. Now, this is the typical spindle cell lipoma, what I've seen typically in the past, where you have a triad. You have mostly fat, the adipocytes. You get these bland spindle cells that are often in a myxoid stroma, and then ropey collagen. So that ropey collagen, which is what I was seeing in the Antony B areas, was basically part of the ropey collagen and not the shredded carrots of a neurofibroma. This is really classic spindle cell lipoma. These are strongly CD34 positive. They show loss of RB. They're almost always in men, like 90% are in men. They're almost always in the posterior neck, shoulder, or like upper back. They're usually subcutaneous. They often have a very myxoid background. Most of the ones I've seen have a very prominent fatty component, very uniform spindle cell population, not like hypercellular, hypocellular like I saw in my schwannoma-like spindle cell lipoma. And they're often in this myxoid background. So much so that the differential could be a myxoid liposarcoma. But again, different location, superficial. Myxoid liposarcomas are usually deep. They don't have the right vascular pattern. They obviously are very different molecularly. These have loss of RB, 13q alterations. They're part of a family of tumors, which I'll get into in a second. If you see these in women, which a small percent are in women, they're usually in non-classic areas. So they may be in the thigh or arm or something like that. But this is a spindle cell lipoma, again, strongly CD34 positive. This was one that I had many years ago, and this is kind of reminiscent of the case I have now, but again, it's still much more uniform. It doesn't have that hypercellular, hypocellular areas, but notice that it does have palisading. Spindle cell lipomas are known to have some palisading. I thought that my case was over the top, but this is pretty prominent as well. In this case, even though it's a spindle cell lipoma, has virtually no fat. So again, this is an example where if it's in a classic location and it's a classic, age and 40s, 50-year-old man, you need to think about it and do the stains no matter what it looks like, which is kind of the lesson that I learned from this case. So this is a spindle cell lipoma. Like schwannomas, they're typically encapsulated. They are benign. They have no malignant potential. They usually don't recur. The problem with schwannomas, which this is an example of a schwannoma, the problem is that they are also typically in the head and neck. So they kind of have very similar clinical distribution. They're typically 20s to 40s, more often men as well. Again, look at this Antony B area. It has that kind of ropey, wiry, shredded carrot collagen. So a lot of similarities. So, again, this is a good case. Very similar looking, and maybe this is a little more elongated, spindled, a little more palisading, but again, I think compared to the case we had, the spindle cell lipoma, I think it's pretty similar. They often say you don't have to do S100 for a classic schwannoma. I don't know if I'm going to live by that anymore. I think I'm probably going to do it for a while. One of the attendings I had at Mass General used to say, like with frozen sections, he used to get bolder and bolder and bolder on frozen. And then he said eventually you make a mistake and then you back way off. He's like, it's like stealing a cookie in a candy jar. You're going to keep stealing it until someone slaps your hand, and then you're going to like hold off and not steal it for a while. Now, speaking of unusual schwannomas, this is a schwannoma that has giant rosettes. This is also called neuroblastoma-like schwannoma. It's very unusual, very small round blue cell, but if you did a Ki-67, it would be very low. The differential with this would be a low-grade fibromyxoid sarcoma. Again, these would be strongly S100 positive. They're MUC4 negative. No fuss alterations, obviously, like low-grade fibromyxoid sarcomas. And then here's this really prominent calcification. That's one of the metaplasias or changes you can see in schwannomas is like osseous metaplasia, chondroid metaplasia. You can have really prominent calcification. Now, obviously, a good lesson for this case is that not everything that has palisading is a schwannoma. This is a case where you could see kind of a vague palisading where you get these kind of nuclear-free areas, a little more clumping of the nuclei. Very spindled looking. You could think of schwannoma. This absolutely could be a schwannoma. But then we're in the small intestine. So what is this? This is the gist. Gists are not uncommonly have areas of palisading with the nuclei, nuclear-free areas. Leiomyomas, same thing in the uterus. You can see palisading. And then this is kind of a very prominent case of palisading in a breast biopsy. So this is something called a myofibroblastoma. They're about they used to be thought to be only in men's breasts, but they're actually with mammograms, they found little small ones in women. So they're actually equal in men and women. They are molecularly very similar to spindle cell lipomas. They have the same RB loss. They're CD34 positive. These are also ERPR positive. Same with cellular angiofibroma. That's this triad of tumors that are characterized by loss of RB. Myofibroblastomas, which have prominent palisading, which you can see, are usually in the breast. You can have extramammary myofibroblastomas also. You get cellular angiofibromas, typically in the groin genital area of both men and women. Again, they're all very similar tumors, CD34 positive, often show palisading. It's something you just need to keep in mind. These tumors are not neural and they show palisading. All right, case 3. So this is a 54-year-old man who had a history of colon cancer diagnosed 2 years prior, now with a left testicular mass associated left-sided hydronephrosis. So he did a left radical orchiectomy. And I showed you this gross. I think I sent you this gross. The point of me sending you this gross is so that you could tell whether this is intratesticular or paratesticular. And you can see that this is pushing the testicle off to the side. So this is a paratesticular mass. So that automatically, before you even look at it, you know that this is not going to be a germ cell tumor, a Sertoli cell tumor, any sort of intratesticular tumor, it's not going to be. Now, when you deal with paratesticular masses, that's a really prominent stromal component. So you see a lot of stromal tumors, sarcomas, you can get adenomatoid tumors, which is not a stromal tumor, but I always think about stromal tumors when I'm dealing with paratesticular lesions. And so let's look at what this one looked like. So this person had a history of colon cancer. So again, you see the seminiferous tubules here. You see the tunica, and then outside of it, you see what looks like a adenocarcinoma with a lot of mucin. Person has a history of colon cancer. Is this colon cancer? Yeah, it is. This is metastatic colonic adenocarcinoma. Now, could other mucinous adenocarcinomas metastasize to the paratesticular area? Sure. But this is just an unusual example of a testicular or paratesticular metastasis from a colonic adenocarcinoma. The other thing that I've talked about multiple times with you guys that you can see here is that when you have something and you're not sure if it's a metastasis and it's like in the ovary or something, you're not sure you're doing with primary mucinous carcinoma or MET, you look for this multi-lobulated, multi-nodular growth pattern where you get these kind of abortive looking nests at the periphery, more kind of mature looking stuff in the middle, well differentiated. Again, here's another nodule. You go to the periphery, especially with these mucinous adenocarcinomas, they often have these little buddings that go off in the periphery. That's a very, very classic appearance of a metastatic mucinous adenocarcinoma, whether it's coming from the colon or somewhere else, pancreas, stomach. So, but what you do in these cases is, you know, if you have the prior, pull it. So this case, that was from 2021, actually. So the colon cancer was from 2019. So if I pulled the colon cancer and it looked like a medullary carcinoma or some other morphology, and now I have that, well, then that might not be a MET. I think it's the most important. Dr. Young, the well-known GYN, GU pathologist in Mass General, used to always say the most important stain is an H&E, which of course someone who's older is going to say that, don't like immunostains. I don't really like immunostains anymore as much, but obviously after my schwannoma, I have a new appreciation for immunostains. But then look at this looks just like that paratesticular cancer. So this is consistent with a metastasis. Now, this ended up getting sent out to another academic institution. They called this adenocarcinoma with mucin-rich features. That's not fucking helpful. You know, I mean, if you know someone has a colon cancer and you want to send out something like that, make an effort to get the prior, compare it. You know, that's why a lot of clinicians don't like pathologists, is because they hedge too much. Now, sometimes hedging is important, but when you have a case like this where the person has a known colonic adenocarcinoma and you have a morphology that looks like that, just call it metastatic colonic adenocarcinoma. Now, if the person also has a new esophageal mass and they want to know which one is it and you can't tell, well, then that's different. Then you hedge or you favor one or the other after you get it. But you don't just sign out everything descriptively. That has a time and a place, but a case like this where the person has a known primary and you have access to the prior, you don't sign it out like that. That just kind of makes you look ridiculous, I think. Now, METs to the, actually, let me show you. So this is a mnemonic that I've told a couple of you before, and it's something I came up with this before I lived in the South. It sounded very Southern. It's to how you know what testicular tumors to think about. Yes'm. Now that I lived in the South and hated it, I no longer use this mnemonic because I don't want to think about anything sounding like the South. But it's still helpful in the sense that it's a good way to remember what tumors occur at what age. So it's not really age 0, but really young kids are more likely to get yolk sac tumors. Embryonal carcinoma is more often in like the 20s, early 20s. Same with mixed. You could also put mixed germ cell tumors are more common in like the 20s. When you get to like 30s, early 40s, that's seminoma, classic type. Around 50 or so, that's spermatocytic tumor. It used to be called spermatocytic seminoma. Remember, those are benign tumors. And then once you're 60 or above, then you start thinking about lymphoma, metastasis. And when you're dealing with metastasis, the common ones are prostate and lung. Those are the two most common. Melanoma is also there, and colon cancer. So this isn't that unusual, this case, for it to be colon cancer. Now, the one thing I'll mention is that juvenile granulosa cell tumor, if you have a boy under the age of 3 months, it's almost always going to be a juvenile granulosa cell tumor. That didn't really fit into my yes'm, but just try and remember that. And so this case is a MET from the most common. This is prostate. So, and now look at, this is a little weird looking for prostate. This is the ductal variant. So this is a mixed acinar, which this looks really classic, kind of acinar Gleason grade 4. And then this is more ductal adenocarcinoma, which is also graded as a Gleason grade 4. Those are not infrequently mixed. They're typically behave high grade. This obviously metastasized to the testicle, and it's within the testicle. These are all ischemic, atrophic looking seminiferous tubules where you just have like the ghosts and kind of elastotic fibrous tissue. But that is the most common met. This is a case I had, and this was a met from, show you, see if you can think of it. That's pretty salt and pepper. This was a metastatic, well-differentiated neuroendocrine tumor that they thought was a primary. That's why they did an orchiectomy. They usually shouldn't do orchiectomies for mets unless there's some reason, but this is within the testicle. This is not paratesticular. So could this be a primary testicular, well-differentiated neuroendocrine tumor? Absolutely. In that case, that's a monodermal teratoma, which are 15 times more common in the ovary than the testicle. So that'd be really unusual. They usually are prepubertal, so they're not associated with germ cell neoplasia in situ. So looking for that is not going to help you in the setting of a well-differentiated neuroendocrine tumor because they're not going to be there. The fact that this is multifocal favored to me that this was a met. You could do CDX2 and stuff that can help you, but you know, these, when they arise, they typically arise in a teratoma and they kind of are GI origin. So they might be CDX2 positive. They're usually not, but that's not necessarily going to help you. To me, this kind of multifocality is much more helpful. Now, interestingly, the majority of testicular mets are actually solitary, but the vast majority, like 90%, have a history of a malignancy. So, you know, there's kind of pluses and minuses. They're going to trick you by being solitary, but you should have a history. Now, this was a paratesticular tumor. So here's the testicle, reedy testis, vas epididymis. And this was a case I had where this looks like a sarcoma. Now, one sarcoma I want you to always think about in the paratesticular area is a dedifferentiated liposarc, because that's pretty common in that area because the lipomas are very common. This was a case that looked more spindled, very pleomorphic. I basically did a bunch of immunostains. It was strongly Desmond SMA positive. The one skeletal muscle marker that we had at the time, I think, was myoglobin, and it was negative. So I called it like a high-grade leiomyosarcoma. But it had very rhabdoid areas, but you know, that's not specific. Rhabdomyosarcoma is not uncommon in the testicle. Usually it's more kids and it's kind of other types, not, this would be a pleomorphic rhabdo. So it got sent out because the patient went somewhere else, and they had, which was relatively new at the time, MyoD1 and myogenin, and they were positive. So this is a pleomorphic rhabdomyosarcoma. So I screwed that up, but there was nothing I could have done other than send the block to some reference lab to do other skeletal muscle markers, which I guess technically could have done, but otherwise this could absolutely be a high-grade leiomyosarcoma. So because it has the underlying Desmond positivity. So that's something to keep in mind, not forget about doing the skeletal muscle markers for things like this. Now here is another paratesticular mass. This was a younger person. And this has kind of a small round blue cell pattern in this nested pattern. And then you start to see these kind of multinucleated, very eosinophilic looking cells that when you look closer, it looks like they have some possible striations. This is an alveolar rhabdomyosarcoma. This is much more common than pleomorphic rhabdomyosarcoma. Embryonal rhabdomyosarcoma is also seen particularly in genital areas, particularly in women with the sarcoma botryoides arising in the vagina or sometimes the cervix. But this is alveolar rhabdomyosarcoma. You know, they're FOXO1 mutations. And then this is another paratesticular mass that was growing along. It has a cover slip's kind of screwed up, but this was very infiltrating, and I don't want you to forget about this lesion in older men. This is a mesothelioma. You get mesotheliomas of the paratesticular area that often present as hydroceles. You can see this kind of hobnailing, atypia, distinct nucleoli. As opposed to the lung and the pleura, these are almost always epithelioid, sometimes biphasic. You almost never get a pure sarcomatoid desmoplastic mesothelioma in the paratesticular region. They typically have this tubular, papillary tubular, cystic morphology. They also are associated with asbestos, slightly less so than the pleural ones, but still they usually are asbestos related. They can metastasize everywhere from here, including the brain. Now, the more common mesothelial lesion that you see is this one. This is often in the tail of the epididymis. Here's the epididymis. It's, even though it looks infiltrative close up, it's well defined. The other thing that you see these lymphoid aggregates. You see these lymphoid aggregates, well-defined lesion, kind of tubulocystic. This is an adenomatoid tumor, as opposed to that mesothelioma, because you can have adenomatoid areas of mesotheliomas. These are very bland. You don't see prominent nucleoli. The staining pattern will be the same, although these will be positive for BAP1. Obviously, mesotheliomas are often show loss of BAP1. But again, this kind of lymphoid aggregate on the periphery is typical of adenomatoid tumor. It's, I think, the most common paratesticular tumor, along with lipoma, leiomyoma. Those are the top three. Again, it usually arises from the epididymis. This is benign, but when you look at it under the microscope, it often has a kind of an infiltrating appearance surrounding smooth muscle bundles. But overall, at low power, it's well defined, and these are benign. All right, case 4. Last case. So 88-year-old woman, 2-day history of worsening epigastric pain. That should be right upper quadrant tenderness. An abdominal CT scan showed a gallbladder distension with gallstones, fat stranding, etc. So they did a cholecystectomy. So this is not going to be satisfying, because the terminology on these lesions is all over the fucking map. And no, even the WHO can't decide about this, but let's just discuss it a little bit. So this is the lesion. This is something I saw grossly. So this is small. It was only a few millimeters. It has these very compact tubules. The reason I wanted to show you this is because if you see something like this at the GE junction, this looks like high-grade dysplasia. Very kind of relatively, increased NC ratios, hyperchromatic nuclei. It doesn't have the loss of polarity. So, when you really scrutinized it, you might not call it high-grade dysplasia, but the architecture is very classic high-grade dysplasia. This is not high-grade dysplasia. These are actually typically benign lesions. I call this a pyloric gland adenoma. So that's what we called them many years ago. Now the terminology has changed in the WHO. If this was over a centimeter, they would call it an intracholecystic papillary neoplasm. But usually under a centimeter, it's kind of a variant of a pyloric gland adenoma. Now, most pyloric gland adenomas have much more mucinous cytoplasm, but they typically have findings that look like low-grade dysplasia, where you have these kind of elongated, hyperchromatic, slightly pseudostratified nuclei. But these look kind of like they're little pyloric glands or maybe biliary type glands. So with the intracholecystic papillary neoplasm, there's kind of 4 types. There's the gastric type, biliary type, which is the most common. You get the intestinal type, which looks like an intestinal, like tubular adenoma, and then oncocytic, which is the least common. So these can have high-grade dysplasia. Even when they do, once the gallbladder's out, they are fine. They do fine. There's no malignant risk. But these can give rise to malignancies. But again, I call this a pyloric gland adenoma. It was not papillary at all, like a true intracholecystic papillary neoplasm is. Now, this is a bigger one that I had several years ago. Called it the same thing. That's what we called them then. This is under a centimeter. But it's interesting, there's a new terminology, a new diagnosis that's come out in the last several years called the intracholecystic tubular non-mucinous neoplasm. The WHO does not recognize that new terminology. They actually lump them under usually pyloric gland adenoma, which is what I call this, or intracholecystic papillary neoplasm if it's over a centimeter. The interesting thing about this intracholecystic tubular non-mucinous neoplasm diagnosis is that they describe in the literature that they often have morular metaplasia, which would stain positively beta-catenin. Just like last month when I showed you those endometrioid cases with morular metaplasia, I did not even really appreciate this several years ago because this lesion was not described. But that's what this is. This is probably an intracholecystic tubular non-mucinous neoplasm. There's morular metaplasia all over this. And about 50% or more of these ICTNs have morular metaplasia. But again, you can call them, the WHO would just call this a pyloric gland adenoma. And then obviously comment on the dysplasia. Just to show you the typical polyp that you see. You know, those pyloric gland adenomas are like 10% of the polyps. Almost 90% of them are these. These are cholesterol polyps, usually arising in the background of cholesterolosis. These have a very thin stalk, so a lot of times when you get the microscopy on these, you don't even see them attached to the underlying wall. They're often very flimsy. These can break off and cause symptoms like a patient would have with a stone, even though they're not stones, and the patients may not have stones. So, you know, obviously what you see is this very cauliflower-looking growth with tons of stromal foamy macrophages. And that's just the typical cholesterol polyp. Another lesion that is often at the gallbladder fundus, that's kind of the diverticulosis version in the gallbladder, is this adenomyomatous hyperplasia. It's usually in the fundus. When you gross it, it looks like a thickened, spongy area. Now, these can have dysplasia in them, and they look like they're kind of infiltrating through the muscle. So these can mimic an invasive carcinoma, but they should still be relatively bland. They should not have any sort of desmoplasia. Now, this is one that has a lot of pyloric gland metaplasia, which is relatively common in the gallbladder. This looks more the typical pyloric glands with the more mucinous cytoplasm, as opposed to a lot of the pyloric gland adenomas that are more mucin poor. But this is adenomyomatous hyperplasia. It can look very scary at first glance, like a large duct invasive adenocarcinoma, but it's still relatively well formed, typically still confined. Occasionally, these can get obstructed by stones and cause mucin rupture, and then it gets really difficult. In those cases, you often have like a xanthogranulomatous cholecystitis, so that should help you. Just to show you a couple other things that you should think about when you have these gallbladders is always look at the vessels. Don't leave a gallbladder until you've looked at the vessels. So what's going on here? That would look like there's more inflammation in that one. This one just looks like almost like a reorganizing or organized thrombus, like medial sclerosis, hyperplasia, but then other vessels have more active inflammation. This is an actual vasculitis involving the gallbladder. How do you sign these out? You sign them out the same way, active small vessel vasculitis. These are by definition, what you're going to see under the microscope is going to be small vessel. Now, whether the person has a medium vessel arteritis, like polyarteritis nodosa, or a true small vessel vasculitis, microscopic polyangiitis, which is, you know, associated with P-ANCA and MPO antibodies, that is for the clinicians to decide. The majority of these, like 2/3 of vasculitis of the gallbladder, is actually involvement by a systemic vasculitis. The other third is actually single organ vasculitis confined to the gallbladder. Those are cases that these patients are fine. They're cured after you do a cholecystectomy. But sometimes this is the first manifestation. So every single report, when you see this, and you're going to see this, if you're looking for it, you're going to see it. I've seen it several times. You have to tell them they have to do serology and an autoimmune workup on these patients, because this could be the first manifestation of a systemic vasculitis. Most of those patients do have systemic vasculitis. Now, the last case is this gallbladder that the other thing you always want to look for is always look in the lymphatic spaces in that subserosal area. This is another high-grade serous carcinoma. Look at those prominent nuclei. Just like that breast case that the differential was primary breast versus, this is kind of the very homogeneous looking chromatin, prominent nuclei. This is a very, very subtle metastatic serous carcinoma. These patients almost always have a history, but a lot of times they've been treated and they're in remission. And then they present a year or 2 years later with symptoms of cholecystitis. They take it out. You got to look in the lymphatics. Sometimes it's not in the lymphatics. Most of the times it's transcelomic, meaning it's just kind of covering the surface, but you'll just have little kind of nodules of serous carcinoma on the surface. But always look for that. It can be really subtle. All right, 9 o'clock. I told you I was going to finish on time. I knew it. I knew it. Too bad I can't diagnose my spindle cell lipomas with that accuracy. All right. Any questions? So this is your last one for the academic year. So I will actually, the next one is going to be August 1st, I think. And I'm going to be in person. So I will be coming back from a vacation on the Pacific Northwest National Parks. So I should be in a good mood. Anyway, no questions, then I'll say goodbye.
Amazing. Thank you so much.
Thank you.
Thank you.
Thanks a lot.
Thanks. I'm going to talk to you guys later.